some might not be relevant to you, so just bear with me as we go along. What we really know, and we've known this for years, is that dengue is endemic in many countries of the world. Endemic, India has remained endemic through the centuries. And if you look at the diagram there, right from the 40s to even now, India has always remained endemic. And it has remained endemic even when the virus subtypes have been done for all the subtypes, so then 1, 2, 3 and 4. For all the subtypes, India has remained endemic. It's a huge public health problem. More than 400 million people are infected with dengue viruses. These are official figures. 100 million become ill and about 21,000 deaths each year because of dengue. And again, official figures. The real ones are probably a few multiples of these. We know dengue fever is a typically tri-phasic disease. You have an initial phase where there is fever. You might have drop in blood platelet counts. You would have rise in hematocrit. And then there is a phase when things settle down. Effervescence happens, fever settles. Parents are happy and we are concerned. Because that is the phase which is the leaky phase, or which is the phase which is going to be more concerning for us. The majority of children and adults would fall into this category of non-hemorrhagic fever, and this is something that we are not going to discuss today. So this is not the topic of our discussion today. Non-hemorrhagic fever is usually managed as an outpatient. Most of these children will have myalgias, fevers, some might have lethargy. A few of them, especially infants, might have very poor oral intake, and you might need to admit them to give them hydration or give them IV fluids. But again, majority of them would not need to be admitted and can be managed as outpatients. But the topic for our discussion today is the severe dengue, as the WHO has now classified it. Rather than calling it the dengue hemorrhagic fever or DHF, it is now called a severe dengue. So dengue is now classified as dengue with or without the warning signs. And if you have warning signs plus any of these, severe plasma leakage, severe hemorrhage, or severe organ involvement, that becomes severe dengue. Right? So this is what we are going to discuss in a bit more detail today. And just to highlight it, I'm going to start off with a case, a typical case, a very scary sort of scenario. 11-year-old child weighing about 72 kilos, comes with fever, pain abdomen for 3 days, which then settles for a day, and again he starts having fevers. He's lethargic for 2 days. He's admitted for poor oral intake and lethargy, and you can see his vitals, heart rate is 130, respiratory rate is 30, blood pressure is 88 by 70, capillary filtration time of around 3 seconds, saturating around 95% on 2 liters of oxygen, hemoglobin 12, TLC 13,000, platelets 1.2 lakh, SGOT, SGPT slightly raised creatine and the NS1 antigen is positive. A typical scenario, you do an X-ray and there is a hint of some pleural effusion happening on the right side. Gets admitted, gets the usual medication that most of children would get. This child got a fluid bolus of normal saline, 20 ml per kilo, got IV fluids, antibiotics, some oxygen monitoring, and as it happened, often in this subset of children, and I like you to think about this child again, 11-year-old, 72 kilos. So an adolescent who is slightly overweight is somehow always a huge red flag for us. These are the children who really sometimes often do very poorly. So next 2 days the child worsens with more distress, agitation, shouting intermittently. He is consolable, but he is agitated, gets referred, and when he comes to the emergency department, we find his heart rate to be high 170, his blood pressure is 80 by 68. So if you look at the number, it's a narrow pulse pressure. So, and the pulse volume is low, cold clammy extremities, and the capillary fill time is elevated, about 5 seconds. He's agitated but responsive, he's conscious, refuses to keep on the oxygen mask, keep throwing it out. Is now saturating 92% with about 12 liters of oxygen by mask, and the urine output has dropped. It's about just 15 cc in the last 3 hours. So we know this child is now progressing into severe dengue. And there are few markers here which are always very concerning. A child with very poor blood pressures, sometimes even unrecordable blood pressures, and conscious. So these are children who remain somehow conscious, agitated. They will be talking to you, asking for food or even water, and they are so cold that it is actually very, very distressing. And on investigations for this child, you find a hemoglobin of 13, a count of around 8,000, platelets have dropped to 42,000, INR is 2, APTT is deranged, urea creatinine mildly deranged, the liver enzymes are shot up to thousands, the CRP is 12, and the ferritin, which we often get done as a marker of inflammation, is 18,000. So we expect normal ferritin to be under about 100. And ultrasound shows the typical feature of dengue: bilateral pleural effusions, some ascites, and gallbladder wall edema. So, typical setup of a severe dengue fever. And as the WHO has classified, this child falls into all the features of severe dengue. There are features of leakage, of dengue shock syndrome, fluid accumulation, and respiratory distress and organ involvement. So, what is new in dengue, or how do we understand dengue? We have, this slide is important more in the sense that this has implications in the treatment of dengue. We know that the first time you are infected with any virus, your body launches an immunological response, and there are memory cells which are formed. The second infection, depending on whether you get the homotypic, the same type that you got as the first one, or a heterotypic, a second virus, decides the course of the disease. If it is the same homotypic virus, the neutralizing antibodies are produced which control the infection. On the other hand, if it is an infection with a non-homozygous or heterozygous virus, so if it is Gen 1 in the first and Gen 2 in the second, there are a lot of antibodies produced, but they are non-neutralizing antibodies, and this is an inflammatory response which goes haywire. It is an uncontrolled inflammatory response, and this is the real reason for almost all that of what we see in severe dengue. And this is where we are trying to target therapy now. So, hypercytokinemia, which is a part of many diseases, including post-COVID, we have seen in children the MISC, the multi-inflammatory syndrome post-COVID, a massive inflammatory response, something that we see in a juvenile idiopathic arthritis, massive inflammatory response, sometimes that we see in Kawasaki disease, massive inflammatory response. So all of these diseases have actually now been clubbed together as a post-inciting event inflammatory response. So it is not the agent which is that important, but the inflammation which goes haywire which is more important. And more interestingly, this NS1 antigen is protective to the virus. People have started looking at, so far what we have been doing is we look at NS1 positive or negative, whether it is dengue, yes or no. Now people have started looking at the titers of NS1 as a marker of the severity of disease. So if you have a higher NS1 titer, it is more likely to be a more severe dengue infection. So again, the pathophysiology is important because we know this antibody-dependent enhancement, the ABE, is a very important positive factor for a massive inflammatory response. So what can we do? What we can do is look out for the warning signs. We don't do the dengue typing for all the patients. We don't know whether they've been exposed earlier. We can do that indirectly by looking at the IgM and the IgG antibody titers to know whether they've been exposed earlier. But we would want to watch out for the warning signs. Most of them are very clinical, and we are all very well aware of these: abdominal pain, persistent vomiting, lethargy, restlessness, mucosal bleeds, and sometimes, and on the laboratory parameters, we can find increasing hematocrit level. So leaky capillaries is a very important feature of dengue, which So you have plasma which is oozing out and the blood gets concentrated, or you have hemoconcentration or rising hematocrit. People have tried to club many of these features together to give us some sort of a prognostic score, and this is one of those articles which tells us that they've looked at a few things. They looked at the albumin, the liver enzymes, the platelet count, the PTT, and the IgM dengue, whether it's positive or not. And they have devised a score, and this score, you can see it on the ROC curve, it is shifted way to the right top corner. So this has a very good predictability of a severe dengue infection. We probably don't need to remember the numbers, but it is important to look at these parameters when we are looking for a severe infection. So if you have albumin which is low, you have liver enzymes which are very high in 200s, platelet count which is less than about a lakh, deranged PTT and IgM positive, these patients are more likely to be severely infected children with dengue. We are all concerned about platelets. Everyone is concerned about platelets, parents more than us often, and we know platelets are probably not the most important reason for our concern. We can give as many platelet transfusions as you want to keep the numbers right, and the child might still deteriorate, the child might still not do well, because the reason of thrombocytopenia is multifactorial. Immune-mediated thrombocytopenia remains the most important factor, and we do not need to target a number and treat or transfuse platelets just to maintain that number unless it is very low or you have some features of active bleeding. So if you have no features of active bleeding and the platelets are not very low, not very low number can be debatable, but most of us agree to a number of somewhere around about 10,000. So if the platelets are more than 10,000 and there is no active bleeding, you can easily not transfuse platelets. So how can we have any more objective criteria to it? So people have looked at the immature platelet fraction. So most of your pathologist friends should be able to give you this from the counters of most of the modern machines. So these are the immature platelets which have come out from the bone marrow, and this gives you a reflection that the bone marrow is trying to produce its own platelets. So if you have the immature platelet fraction of more than around 15-20%, you can be reasonably assured that in the next 48 to 72 hours, the natural platelet production will be very significant. The catch here is this 48 to 72 hours. Are you willing to wait to sit on a child who has a platelet count of, let's say, 5,000 for another 48 to 72 hours? So, and maybe because of this reason, this immature platelet fraction, it's been around for a while, has never really caught on. So our concern should be this, the plasma leakage. Our main concern, all the problems that we have because of dengue is because of this plasma leakage and the uncontrolled inflammation which is the reason for it. So hypercytokainemia, hyperinflammatory response is what is the main reason for plasma leakage. This is what causes hemoconcentration, and this is the thing that we need to treat. So how do we treat it? There is ongoing fluid loss, so we have to replace this fluid loss. So fluid remains the most important treatment. So we have to replace fluid and continue replenishing the intravascular volume. The question, and a very tricky question especially for dengue, is which fluid to use, how much to use, how fast to use, and this is not an easy question to answer, especially in children who have very severe dengue. So let's look at what happens in dengue. So you have intravascular volume which is low, and you are trying to expand that intravascular volume by giving crystalloids. That is what we normally do. Isotonic crystalloids, normal saline or ringer lactate, you infuse it and you expand the intravascular volume. This sounds simple, and this simplistic approach has been adopted by WHO. So if you look at the WHO algorithms of treatment of dengue, this is exactly what WHO tells us to do. That you give fluid as much as it is required. And their calculations is pretty generous. So So the recommendation for compensated shock, when the shock is compensated, so you have normal blood pressures and they are just features of shock. You start with a bolus of 10 to 20 ml per kg of crystalloid, and then if there is improvement, not worsening, if the child actually improves, then you continue to give a lot of fluid. You give 10 ml per kg per hour for the next 2 hours, and then reduce to 7, then 5, then 3 over the next subsequent 2 hours. So if you calculate for any child, this child in about 4-5 hours tends to get a lot of fluid, right? This is a child who is actually improving. A child who doesn't improve or has worsened, you look at the hematocrit. If the hematocrit is still high, that means the leakage is continuing and you have to give either more fluids, or if you are giving fluids and it is not helping, you can switch to colloids. So that is the whole idea behind this algorithm. You use crystalloids, and if crystalloids are not helping, use colloids. If the hematocrit is dropping on the other hand, it means there is oozing of blood somewhere. There is some internal bleeding and you need to use blood. So that is how WHO has defined it, and it is essentially the same even if the child is in hypotensive shock. The algorithm is more or less the same. The only difference is now upfront we can use a colloid with the crystalloid. So the colloid sort of moves up and you can use this. Rest of the algorithm remains same. Now let us look at this therapy and the problems with this therapy. So the idea is pretty good. You give a crystalloid and expand the intravascular volume. So what happens normally in every normal patient, not even a patient, in any normal healthy human being, if we give a fluid bolus, that crystalloid fluid does not remain in the intravascular space forever. Within the next 2 to 3 hours, 75% of it leaks out. Right? This is when the capillaries are intact. In dengue, we have leaky capillaries. The endothelial spaces are all widened out. So this leak is even more magnified. So rather than just 25% remaining intravascular, it might be maybe 10% or 5% because there is a lot of leak happening. So every fluid bolus that we give adds to the leakage. Where is this fluid leaking? It's leaking to every extravascular space. It is leaking in the third spaces. It is leaking in the interstitium of the liver, causing hepatitis. It is leaking in the brain, causing encephalopathy. Leaking in the heart, causing myocarditis, pulmonary edema. Just about all the problems. So all the fluid that we are giving is not without harm. It is, apart from the direct effect of the virus, the fluid therapy itself is adding to the damage for these children. So this I've already said that after a fluid crystalloid bolus, most of it tends to seep out. Now what about colloid? Right? So colloid are larger molecules. They would tend to stay in the intravascular space for much longer and they will hold on the fluid because of the osmotic effect in the intravascular space. Perfect, fine. But again we are dealing with situation of leaky capillaries. Capillaries, if the leak is significant enough, even the colloid might actually move out. It might move out into the interstitium and it will draw water with it. It will cause more interstitial edema. So again, none of these fluid therapies are without their harm. Be it crystalloid, be it colloid, we have to be very judicious in using them so as to get the benefit and not the harm out of it. So in spite of our best efforts, in spite of as judicious as you would want to be, all dengue treatments are essentially a treatment of fluid overload. Almost every child would be fluid overloaded to some or other extent because of the therapy, and this has its complications. So which fluid to use? This is a landmark paper from New England Journal. It was in Vietnam. 3 different fluids were used: ringer lactate, starch and albumin, and essentially what they showed it was no different. So for resuscitation and maintenance of intravascular volume in severe dengue, whether you use Ringer's or a colloid, it doesn't really make a difference. So Ringer lactate as a first choice of agent is a very good choice. Any simple, cheap Ringer lactate is a good choice to use. But again, in children with severe plasma leak and shock, what you need to remember is they can very rapidly progress and deteriorate. So you can have a child going from just warning signs to compensated to decompensated shock and then to cardiorespiratory collapse within a few hours. So it is not unusual for such children to rapidly deteriorate. And this child, the case that we had, these are all X-rays of the child within a day, within 24 hours. This child comes to the ICU, is ventilated, gets a dialysis catheter and is started on CRRT support all within the span of 24 hours. So sometimes this disease can be very, very rapidly progressing. And the multiple complications of the viremia itself and the associated treatment complications can complicate this very significantly. A number that we often track is the ferritin level. And it is not unusual to have ferritin levels which are very, very high in dengue. So we have learned from our mistakes. About 8-10 years back, we would treat all these ferritins. Every high ferritin we would treat them with steroids and IVIG. But we have now learned that this is not a prognostic marker alone. So just ferritin is not a very good prognostic marker. So another way, you can have a very sick child in the ICU with ferritin level in thousands, and you can have a child who is not very sick out in the wards with a ferritin level in lakhs. So ferritin alone is not a very good prognostic marker, but yes, in the right setup, it might give you some clue as to the degree of inflammatory response. But when there is fluid unresponsive shock, when you are giving fluids and you don't get a response, there is a role for being aggressive or for early use of vasopressor agents. So vasoconstrictor agents which might reduce the leakage, the ongoing leakage. So if 1 or 2 boluses are not helping and the leakage is continuing, we would be quick to add on a vasopressing agent, noradrenaline or vasopressin much earlier. Sometimes you might have myocardial dysfunction as well, and you would want to add some inotropy as well. So as I said, fluid overload is almost the norm, and there are, with the easy availability of bedside ultrasound and echo in most of the ICUs and people learning focus of point of care ultrasound, we tend to use a lot of these equipments. We look at the IVC, we look at the cardiac contractility, and we have non-invasive methods of looking at cardiac outputs as well, like this ICON meter monitor, which gives you idea of not just the cardiac output or cardiac index, but also about the extrathoracic lung water, the lung water, extravascular lung water, which is a good parameter to track on to look at the fluid overload. And as I said, we tend to use IVC distensibility or collapsibilities and the cardiac contractility to judiciously titrate the fluid as much as possible. And again, we are quick on to add another agent to help us reduce unnecessary fluid overload. And it is well known that cardiac dysfunction is not uncommon with severe dengue. Both right heart and left heart dysfunction is well known with dengue, and we have to be aware of this while giving more and more fluids, because with a state of fluid overload, the myocardial dysfunction can often be unmasked when you give more fluids. And there's this paper which was published in the Pediatric Critical Care Medicine, paper from Apollo Chennai, Dr. Suchitra Rangi and her team. They protocolized this, trying to minimize excessive fluid and early use of vasoactive agents, and they showed excellent results with such a treatment modality. So hyperferritinemia and secondary HLH, as I said, we have sort of learned from our mistakes. Not all hyperferritinemia is secondary HLH. But having said that, dengue can be a reason of secondary HLH, and you might have to treat HLH because of dengue if you have all the criteria being fulfilled. So there are WHO criteria of HLH. So not just ferritin alone, but if you have other parameters as well which fit into HLH, you would want to treat that ferritin. But ferritin alone is not a very significant prognostic marker, and people have done studies, they've looked at absolute ferritin levels and even increments of ferritin levels and seen that it does not really prognosticate, consider it's just lying at the zero interval. The recovery phase is very important. In fact, I would say of 10 patients that would get referred to us, 3 or 4 of them we would just be doing this, taking fluid out. So diuresing them or actively doing what we call as a de-resuscitation, which is very important. The fluid which is locked in after the child starts to improve, that has to come out of the system. That is important. So often it is done easily by diuretics. Sometimes you might have to use more aggressive renal replacement therapies to get this. So we started off with this hypercytokinemia model, where we know that this is an increased inflammatory response causing all these problems. So obviously the treatment would lie somewhere there to stop or stem this inflammatory response, and people have tried to look at these. And a very obvious choice is steroids. So why not give steroids to everyone and stem this inflammatory response? Sounds good, but it has not shown us benefit in most of the cases. Something which is promising and is coming up and people are using a lot more is this anti-IL-1 anakinra, which is supposed to reduce the inflammatory response. The problem is we don't know at what stage should we use it. If you use it for everyone, you will probably overdo it. It is a very expensive medicine, and as of now, in India at least, available only through the black market. So it's a very expensive medicine, so we still have to be judicious with its use. Some of my colleagues down south who have used more of this, they vouch for it, that it really changes the course of the disease. But my personal experience is very limited with anakinra. But steroids, just to put an interesting spin to this, people had looked at various doses of steroids, so low dose versus high dose steroids, and looked at the viremia. So the graph there is of the viremia, so the virus load is reducing irrespective of whether the child gets a low dose or a high dose. So there are two ways of looking at it, that steroids did not harm, it did not increase the viral load, so we might as well give the steroids. And the other way to look at it is, why give it? Because it made no difference. The virus load continued to reduce irrespective of the steroids. So the way you want to advocate it, if you are an advocate for steroids, you would probably say that it is not causing harm, so why not give steroids? This is something that we are all waiting for, some dengue vaccine. There is, all of you might be aware, there is the very recent Japanese vaccine which has been licensed now. It is probably still a couple of years away from coming to Indian markets, but it is very promising, and that might actually reduce the disease burden significantly. So just to quickly summarize, severe dengue is a syndrome with characteristic leaky capillaries. Fluid maintenance is very important. Sometimes you need very specialized care with multi-organ dysfunction. And as of now, there is no real role of steroids to prevent or stem the progression of shock. Thank you so much for your time.